I may make a comment. It's an excellent way of getting drugs to the keloids. The issue is having effective drugs to get into the keloids. The limitations are there. The limitations are not in getting the drugs there, as to get effective drugs in there. So if you come up with excellent methods of getting a drug that is absolutely ineffective, we haven't achieved much. So wonderful way of getting the drugs in, need to work very hard in figuring out good drugs.
Yeah. The point also with the drugs is that often they need to have a long half-life, or if they don't have a pharmacological half-life, that they have a biological half-life, because otherwise you have to do that every second day.
Absolutely.
So I think the drug is essential as well.
Any other questions for Albert?
So the next speaker. Oh, yeah, please.
I just have a question about all the people who did your study. Did none of them ask for a local anesthetic before the injections?
Sometimes we give infiltration or field block anesthesia with these injections, typically not, because otherwise it's difficult when they are extensive or you have many, you can't do that. But pain is a big issue, also with a jet injector, but certainly also with a needle injection.
Thank you very much. So this session is on non-surgical treatments of keloids. So we're using methods other than surgery to treat keloids. And that was Albert's first presentation. I'm going to focus on cryotherapy. And every year, I hope somebody else to do this talk and submit a presentation, but we don't get it. So I end up doing this because I think this is an important method of treatment that is underutilized. So we published the guidelines on treatment of cryotherapy, which is online. This is nothing new. This was developed way back in 1950s for treatment of keloids. There are several publications that basically name it as a very effective method that should be used for treatment of the keloids. So I'm going to share some cases with you, and try not to think surgery. And think if you can treat any of these without surgery. This is a 17-year-old who had this keloid for 2 years with no treatment. This patient has had it for 6 years with no treatments. This patient has had it for about 5 years, has had this intralesional steroid injections, and she refuses to have surgery. This is another patient who basically needed to have cartilage removed from his ear for plastic surgery and developed a keloid inside his ear where the cartilage was removed. Hasn't had any prior treatments. This patient has had 2 surgeries in the past, radiation and steroid injection, has had recurrence, has been dealing with this for about 13 years. This is another patient. This is a post-otoplastic keloid. This patient developed this bad keloid 2 years earlier. He was 25 at the time, has had no treatments. This is another patient who had this very large keloid on her ear, had prior 3 surgeries in the past, radiation therapy, numerous injections of cannula. So let's start with this patient, and let's see what we can do. She basically refuses any of these treatments, and we decided to do cryotherapy for her. I'm going to share with you how this is done, how I do it. Everybody does this slightly differently. So I basically use a kind of cotton swab or something that I make myself, putting rolling gauzes in different size test tubes, cutting the tip of them. And depending on the size of keloid you use to treat, basically you can adjust the size. It's a very simple method, very cheap method, nothing fancy. Everybody can do this. You don't need to buy any major equipments for this. And thus you cut it and you have a flat surface to work with. And then you get your liquid nitrogen to the patient's room. Hopefully this would load. I usually carry it in disposable cups. So after every patient, you throw the cup out. So a handful of cups. And here you just pour some liquid nitrogen in this. Once you're done with this patient, you throw the cup out. So try to keep it as clean as possible. This gets dipped into the cup, and then it is applied to the keloid tissue. That's how I do it. You just dip it in there to soak it with liquid nitrogen, basically. And the glass or plastic tube is, it doesn't transmit cold or heat, so it is very safe to hold it in your hand. For a smaller size keloids, I use a Q-tip that's appropriate to the size of the lesion. You basically touch it. This is contact cryotherapy. You don't stick any needles in there. This is not intralesional, and basically works very well. All you need to do, I'm going to fast forward this. You need to freeze this whole thing. I don't measure the time. Just freeze it until you get to the base of this keloid, closer to where the normal earlobe should be in this case. This is a patient with a larger keloid. These two were done with no local anesthetic. This is a procedure that is fairly well tolerated. From the beginning to, this is a bit fast forwarded. This case took 6 minutes from beginning to the end, 6 minutes only. So you basically continue applying your liquid nitrogen to this until you get the whole thing frozen to where it should be. And then the patient the healing process for this is about 6 to 8 weeks. This goes through a necrotic process, much like a burn. The tissue swells up, forms a blister, oozes and leaks for 7 to 10 days. Patients need to bandage it to control that. They come back, then it turns into a dry scab that is dark black in color. Patients come back about 6 to 8 weeks later. At that point, there is residual disease usually left. This is inducing partial remission already. You treat it again. So you continue treating what is left. 6 months later, patient comes back. This was done in July, comes back in September. There is disease left. You keep treating it. You keep treating it until everything goes away. This takes time. We started June 8, 2013, November 15, 2013. This is completely gone. Once I showed this to a colleague of mine a few years ago, he told me, Michael, are you using Photoshop to Photoshop these pictures? No, this is just straightforward cryotherapy. This is another example of a patient who is Indian origin, never wanted to have any surgery, was treated with the same method. These are the kind of results you can achieve, repeating the same method of treatment I showed you before. That was her left ear, this is on her right ear. I'm sure you can operate on these. I'm sure you can do all kinds of methods of treatment. These are basically simple cryotherapy. This is another patient who had this keloid in there. I'm sure you can go in surgically to remove it, but we basically try to freeze it. You freeze it once in January 19. She came back March 9. This is already smaller. You freeze it again, becomes smaller, and this is your end result. And this is what I have achieved. We were able to achieve in a matter of 6, 7 months. This has not recurred. This patient already has been through several surgeries and radiation therapy. And again, yeah, you can obviously operate on this, remove it, and perhaps end up with more deformity of her ears. But we decided this is the posterior view of this. This is the blister you get after the cryotherapy. This is basically within a few hours of treatment. This was treated with cryotherapy. And again, this is after recovery 2 months later. This already became smaller. You repeat your treatment, you repeat your treatment, you repeat your treatment, you repeat your treatment. This patient came back 3 years later with a minor recurrence at this area in the lower part. I cannot get this cursor to show it there. But that was treated with intralesional chemotherapy, that spot. When it is something minor, I use intralesional chemo. And then this is 5 years later from the time we began. The deformity and loss of tissue is from prior surgeries that was performed on this patient on her ear. This is 6 years later. This is the other gentleman with this very massive post-otoplasty keloids who was actually 23. And I want to show you how I did the cryo for this one. So the tumors that are larger, you can be creative and basically dip it in liquid nitrogen. This is a cup filled with liquid nitrogen. You basically dip it in there. I have to be careful not to basically induce freezing in the tissue underneath. So you have to monitor the site constantly. You get as much freezing as you can by dipping it, then you apply the cotton swab. So this is how much I was able to achieve. This is larger, so I used 2 of these tubes to apply. I use that to freeze it. You continue this method until you get the whole thing frozen. This took perhaps about 20 minutes or so. But at the end, you're able to completely achieve it, freezing all the way to you have to freeze it all the way to the base of the ear. And now let's look at the results. This is after one treatment. This was done on both sides for him. Then the patient came in a serial way, repeated the treatments for him. This was 2013, this was 2014. So in a matter of almost a year, I was able to remove this tumor completely. He came back 2020, right? Let's take a look. 2014, 6 years later, he has a keloid forming here. This was outside the area that I treated. And that was also treated with cryotherapy. And he has been in remission since. This is the other patient I showed you. And again, she was treated with cryotherapy, same methods. You can induce the tissue necrosis. As a result, the keloid reduces in size. So we started, let's look at the time frame here. 2015. So it took a while. 2017, she came back. She had some minor regrowth here. It took 3 years, and she had more regrowth. This was again treated with cryotherapy. The one point I would like to make here, yesterday I showed you a slide how negatively surgery impacts biology of keloid. I showed you that one case that there was no response to any form of method of treatment. This patient has gone through the standard treatment. It took 7 years to get from here to here, right? This is cryotherapy 7 years later. This tumor did not become 10 times the size after 7 years. There was regrowth, but at a much slower rate. So cryo did impact the biology of this disease, slowed down the rate of regrowth. But that was the rate of regrowth in 7 years. This is the rate of regrowth. So the strategy for treatment of keloids that are nodular and small, basically you need to have a strategy in treating them. Yesterday we talked about strategy. So cryo not only doesn't carry a risk of worsening of it, but positively impacts the biology of the disease. So from what we learned in these patients with much larger keloid, we come to this patient with a much smaller keloid. And the reason we come to this patient is that she's not alone. There are many other patients who have these minor keloids on their ears, right? What we want to do, we want to treat these patients. We just want to avoid all these very large keloids because all these massive keloids on the ears, they started very small. At some point, nobody wakes up with these massive keloids on their ears. Fiona, you picked at this point, these keloids can grow to this size, but majority of these patients that you see here have had prior surgeries. All of them, not majority, all of these patients have a prior surgery. Most of them have had radiation therapy. So the strategy is we need to treat these small keloids, no doubt, but however we treat them, we want to make sure we don't end up there. That's the strategy. And how do we get there? In my opinion, avoiding surgery for these small keloids. This is another thing you want to avoid. This is direct result of surgery, loss of earlobe and ear tissue and ear contour. If we not use surgery, we don't end up there. So these are the things we want to avoid. As a result, we're going to not operate on this patient and see what we can do with cryotherapy. You freeze it, you freeze it, you freeze it. You freeze it, this becomes flat, there's some loss of pigment there, and you end up with fairly decent result. This has not had a recurrence. This did not go through the path that can potentially end up with a very large keloid. It took almost a year to get there though, right? This is another patient who has keloids basically protruding from both sides. I'm sure surgically this is something you can easily treat, but this is the result you can achieve with cryotherapy. This patient didn't listen to me. I tell all the patients not to pierce their ears. This patient, her keloid got better and said, well, I'm going to pierce my ear. Tirgan will fix it for me if I develop a keloid. So this is not photoshopped, John. So this is another patient who actually came to visit me herself after this keloid was treated, and she required 3-4 courses of treatment. These are other examples of the results you can achieve with cryo. This patient, and cryo is most appropriate for tumoral type keloids, tumors that grow like a mushroom, basically. This patient required only 1 cryotherapy to achieve this. 1, John. This was done February 14. On Valentine's Day, she came back April 11. But you're not done with this patient. This patient, there is minor keloid left there. At this point, this needs to be treated with intralesional chemotherapy. So when we do studies, if we just do surgery and we do cryotherapy, we are not done. If there is minor recurrence, we should not be leaving these patients alone. You need to treat that recurrence. Or we notice there is a tiny recurrence that needs to be treated with intralesional chemo, then that becomes your treatment protocol. You debulk with cryo, continue manage any potential minor recurrences with intralesional chemo, and I'll go through the chemo in a bit. That becomes your protocol. Then you have treated 100 patients with this protocol. Let's see what the outcome is. So this patient needs treatment for that. We're not done with that. This is another patient, had 1 course of cryotherapy. We achieved significant debulking of these keloids. This is basically life-changing, makes patients feel better. I'm sure we can operate and remove this surgically and radiate them, but you induce decent results. And think about this. Not everybody has access to great plastic surgeons, great radiation therapists. People live in Africa, people live in Morocco, people live in places that there are no hospitals around them. There are no specialists around them. There is no radiation therapy device around them. We need to think globally. We cannot just think about Royal Marsden in London and how best we can treat keloids. We need to think how best we can achieve good results for great majority of patients around the world. You can teach the method of cryotherapy that I showed you to a medical student, to a nurse, to treat under supervision of a physician. You don't need to take the patient to the operating room. You don't need to have the patient be on a waiting list for 6 months to see a plastic surgeon or go to radiation therapy. These are other examples of what you can achieve with simple cryotherapy. So in my opinion, it's a better alternative to surgery almost for all ear keloids, early stage ear keloids, and it's fairly easy to administer. Pain for larger keloids need to be managed. So you all know how to manage pain. I use a liposomal form of bupivacaine that's available in US that stays in the tissue for up to 3 days. For keloids that are larger than 2 centimeters, I use that. And we have basically published this in one of our clinical trial guidelines. I'll take any questions you may have.
Thank you. You don't combine the cryo with injections at the same session?
None of these patients have had cryo and injections at the same session, no.
I talked to some of the people here and, well, I heard from somebody who says, I do at the same session, first the cryo and then I inject it. And I talked to somebody else who said, I first inject it and then do the cryo, but at the same session. Do you think it would be maybe more effective, maybe less recurrence if you would combine it in the same?
Depends on what keloid you treat. As you saw, I'm showing ear keloids. Cryo is an excellent method of treatment for ear keloids, any form, any size, any shape. Now, I give credit to you. I mean, for that very large keloid, if I have a very good plastic surgeon nearby, I have him to excise much of that keloid, leave the normal anatomy underneath, then you treat the rest of it with cryo. But as I showed you yesterday, if you're treating a chest keloid, chest wall keloids, or shoulder keloids, these are not keloids that you can treat and get the results you can achieve with the ear keloids. And that first patient I showed you, if I decide to use cryotherapy, I definitely use intralesional triamcinolone combined with cryo. On the chest for small lesions. If a lesion that is 4 centimeters on the chest, I may not use cryotherapy. So for every patient, for every size keloid, you need to have a particular strategy.
Yeah, there was a study done that the combination of cryo with corticosteroids happened to be better, with a better result than cryotherapy alone.
Right.
But don't know if it's only the...
Yeah, for that patient with the ear keloid, I would have simply treated it with cryo, the method I did. I would not cut that.
Well, the other thing is what I found very interesting. If you do cryotherapy only on an ear and it heals, it always gets the same shape of the ear before it was before it actually had a keloid, and that's quite strange. So there must be an inherent model in ourselves of the ear becoming an ear again. Because when you do an operation, I have to do my almost upper best to get the shape of the ear. So that's interesting, and I think that's the reason you have to consider to do cryotherapy instead of surgery if you're not a brilliant plastic surgeon.
Give me 1 minute. Let me share this other patient with you. This is a patient that was next presenting. This is a young patient who has had multiple surgeries, and you can see how deformed opposite ear her left ear is. And we treated her in stages, I treated her in stages, different times, different parts of her keloid. And this is the kind of results you can achieve with that. You bring the normal anatomy back. Yeah. Even in this ear that is totally deformed, you can actually achieve decent outcomes.
Dr. Tirgan, you gave us a master class in the treatment. No, I don't want to flatter you, but while I listen...
Flatter me, I'll take it.
Okay. Well, I've been around the world like you, and I never seen results that you've shown, and they can't be bettered. There's no question. 2 masters, one just died. David Hockney just died. Came on my phone. The famous British artist. I'm very sad. Sorry. Wonderful artist. Anyway, he just died today. But what I wanted to ask you, how can you tell with your fingers whether these big keloids you're freezing are completely frozen? Shouldn't you put like a meat tenderizer thermometer in and make sure? Maybe that's why you're getting recurrences.
You don't need to use anything to measure temperature. I mean, I don't. I mean, you can see it. This is deeply frozen all the way to its base, and part of it survives. No big deal. You treat it 2 months later. Yeah, money. You're correct. But this is how this treatment works. You can say, how can you feel it with your fingers? I don't feel it with the finger. I visually assess it, John. To anybody's eye, this is completely frozen. And the way you freeze it, and I showed it in my very first video. If you're freezing, to know that this freezes all the way to the base, is that you don't go around it. You start, say, if you're freezing this finger, right? If you go around it, you may not get the core. But if you only freeze from this end, the frost line moves this direction, eventually moves to the base. Then you get the whole thing frozen. You don't go around it.
Yes. Okay. I have a question. When you do the treatment, how do you control the depth of frozen? The time of freeze or cannot control, because I see in some cases have defect of the ear. So how do you control the depth?
So visually, when you achieve this much freezing and you get to the base of the keloid near the ear tissue, you stop. Because you know some of this keloid is going to survive. You address that 2 months later.
In the defect cases, you think it's need to first like that must defect, or can use some method to avoid the defect of air?
So you avoid freezing normal tissue, completely avoid that, because you visually inspect it. You visually see what you're freezing. This is not blindly done. This is done just under your direct observation under your hands. And the moment you remove this probe from the area you're freezing, the freezing line stops, or shortly thereafter stops. So you're constantly monitoring this.
Okay.
This is very different than putting a probe in it and doing intralesional cryo that you don't know how far it will go.
I have got a question. How many sessions do you do? Do you have a limit on the number of sessions, and what is your interval between sessions?
Approximately, it's for larger keloids about 2 months, and you treat them as many times as it takes until you get everything off. Now, if it continues something like this for 3, 4, 5 sessions, and there is area of the keloid left that is not responding to cryo, then I'll treat that with intralesional chemotherapy, which is my next.
And do you also use it for the flatter keloids, which are a bigger area?
No. This is only for, remember the title, for bulky tumoral keloids. The purpose of the cryo is to debulk. Remove the bulk.
Just to add some information, the keloid tissue is different from normal skin. That means when you freeze the keloid tissue, it will be exactly frozen, but the normal skin has a normal, around the keloid you have a higher blood flow just around the keloid. So that means that the freezing is less in the normal skin. So don't be afraid to go down to the base, because that will not be that heavily frozen that you get necrosis of your own skin. That's what we did with the after surgery as well. So it's due to the fact that it's different tissue.
That's absolutely correct. It's preferential for freezing.
What is your wound care regimen post-therapy, and how long does it take for this to close, and how many pediatric patients have you treated?
So this year I started using AI to produce the data on these patients, to share data. As yesterday said, compliance is very important for patients to continue to come and follow with the treatment. For those who follow, the approximate recurrence rate depends on the prior treatments they have had. If a patient has never had any treatment, a keloid that has never been treated and is a small size, the recurrence rate over next several years is less than 10%. Those who have had radiation therapy and multiple surgeries, there is a higher rate of recurrence. But then this treatment changes the biology of the disease to a point that the recurrence occurs, but at much lower pace. But there is recurrence for patients who have had multiple surgeries, and for these very large keloids, there's almost always recurrence, almost always. For the smaller one, there isn't. That other large, the few patients I showed you who have had radiation, there was no recurrence in those. I cannot give you exact data on that. I started working on it several months ago to hopefully have the data. Maybe I'll have that data for Paris as to what the... But the wound care is just simply bandaging it to absorb the secretions. I do not use anything particular for wound care after cryotherapy, just simple cleaning and bandaging it, because I think this tissue needs to gets dehydrated as soon as possible. The duration of the time that there is oozing and an open wound, it's not an open wound because that skin stays there. It usually doesn't come off. Sometimes skin sloughs off, but usually a dry scab forms within about 10 days on the keloid tissue. The larger it is, it takes longer. The smaller it is, it heals a lot sooner and a lot faster. But I don't use any particular thing for wound management, except for keeping it clean.
Thank you. I think we need to go on, but very good discussion. The next speaker, please. Oh, again, you. Great.
To continue with the cryotherapy, chemotherapy.
Intralesional chemotherapy in keloid disorder. That will be, again, a lot of discussion.
I put these two back to back because, again, always I hope somebody else to stand up and talk about these two topics. And I hope in the future you will be. Some of you spend time in my office with learning these procedures, but it would be wonderful to have others to come and talk about these topics. That would be wonderful. Is it displaying? I had the top. I had the top.
You know him? Oh, British face. He was 88. He's a wonderful. You must look him up.
Okay, can you put it on the Zoom now? So then the next topic I'll be talking about is about intralesional chemotherapy. I'm an oncologist, so when I started treating keloid patients, I noticed 5-FU is being used. So I thought I can perhaps do something with that and try to achieve better results. So 5-FU had publications. There were different response rates reported with 5-FU. So I started using other drugs, and later on that led in forming a clinical protocol for it. Can you help me with figuring this out? Which one is this is the one, right? Okay. And we have this written up. So 5-FU dates back to a long time ago, and Professor Fitzpatrick basically developed it in late 1900s. This is a proof of concept. This is a case that I used intralesional vincristine, trying to achieve better results than 5-FU. This is, pay attention to the dates, October 2013. This is after 5 micrograms of vincristine injected directly into the mass without any jet injectors, without anything, Albert, just injecting with a needle in the core of it. And you can see what kind of response was achieved after 5 micrograms. Repeated it, and this is October to January after 3 rounds of intralesional vincristine, just a tiny bit inside the lesion. This is the importance of having effective medications as opposed to being able, in addition to being able to get them to the tissue. This is another patient I treated with vincristine. She was at the point of attempting suicide. She had 2 surgeries on this. This was extremely painful. It's a young woman who had a lot of issues with this keloid. I treated her with intralesional vincristine. I don't use intralesional vincristine for lesions that are this large. At this point, I use something different, which I tell you. But it's important to see after 1 injection, you can see necrosis and reduction in the thickness of this keloid. This completely resolved her symptoms. She became completely asymptomatic after 1 course of treatment. Of course, carrying her through was a problem because vincristine is a neuropathic drug and causes neuropathic pain at the site of injection that comes a day or 2 after injection. So it's not appropriate for very large keloids like this. I had to keep her on morphine for about 2 weeks after that injection. So after this, I stopped using it for very large keloids. So intralesional chemo is a second-line treatment for most flat and small keloids. After you try intralesional triamcinolone, if it doesn't work, you use intralesional chemo. These are the drugs I use, 5-FU, vincristine, docetaxel. In the publication that we had a few months ago, these drugs are basically well described. I do not use bleomycin. Bleomycin is slightly carcinogen. There were several publications. I treated about 10 patients, somewhere about 10, 12 years ago. Nobody responded in my hands, and that's a challenge. Why is that? The 2 publications reported 70% response rate. I didn't see a single patient to respond, so I don't use bleomycin. These drugs basically work at the enzymatic level in the DNA. I'm not going to go through the mechanism of action of these drugs, but if you're interested, you can certainly study them. The dose of these drugs that I use are extremely low. We talked about dose of steroids. You need to use the minimum effective dose. With 5-FU, it will be reconstituted in 1 milligram per ml solution, approximately. You can never be accurate. So you try to get that concentration. Vincristine is 20 micrograms, docetaxel is 400 micrograms, triamcinolone about 1 milligram per ml. So you start with 5-FU. This is mixed with triamcinolone. You inject the keloid that you think it's going to work in, right? It's not for a huge keloid on the face or in the neck. This is for a flat chest keloid that has failed intralesional triamcinolone. You assess the response in about 2 to 3 weeks. Those who respond to this treatment, you'll know it in about 2 to 3 weeks. You assess the patient. If there is a response, if this treatment is working and response needs to be visually visible, you continue with the same thing. If it is not working, you don't repeat this treatment 10 times. You add vincristine to it. You either switch or add vincristine to it. You try that treatment once, assess the response in about 2 to 4 weeks. If there is a response, you continue with the same treatment until you achieve maximum response. If this treatment is not working or you achieve the maximum response and response is plateauing, then you add docetaxel. This is the third drug I use. If this doesn't work, I stop using any more chemotherapy on the patients. From this point on, if you properly select your patients, you see somewhere about 60, 70% decent response rates, decent response rate. So this is using intralesional. Now, when I say intralesional chemotherapy, is that process, right? You try the first drug, it didn't work, you add the second drug. If it didn't work, you add the third drug. I'm not going to go through all the details of how and which drug it was used for. Every patient is going to be different slightly. So this is where we started in June 2020 with these keloids, and you start seeing gradual responses. We tried cryo here to see if it helps. It didn't. We add Taxid here, docetaxel to it, and we gradually saw better responses. This is a kind of response you can achieve by just injecting intralesional chemo. It's a decent response. This patient returns to my office every 6 to 9 months because has a minor recurrence, minor 2 millimeter recurrence. You inject it with the last set of drugs. This is another patient. In 2013, we treated this keloid with the same method. To 2015, we stopped the treatment. Patient came back 7 years later. This is 7 years later. This has not recurred, has issues elsewhere. So he comes for these other keloids that are getting treated. And this was also treated with intralesional chemo. The lesion that is white up there that achieved a decent response. I know many of you would treat this patient very differently. If I ask you to tell me how you would treat this patient, every one of you would have your own style of treating it. So I decided when I get a patient like him, I don't know, these are keloids that are large that you can try cryotherapy on, you can try chemotherapy on. So on a patient like him, I may treat 1 or 2 lesions with cryo, 1 or 2 lesions with chemo to see which one results in a better outcome, then pick up after that. For this patient, I did the same thing, and it was the chemo that was working better. This is prior to treatment. This is the results in 2022. And this is more recent, 2026. This patient came back, has recurrence here. This was treated exactly with the same method of chemo, last method that used. This is a decent outcome just with intralesional chemo. These are other patients who have been treated the same way. This is a young gentleman who is 20, NYU student, who has had this since age of 15. So, and he was treated with steroid injections for almost 4 years with not much response. He wanted to try cryo first to debulk. We tried it. We achieved some response. Then I treated him with intralesional, you can see 5-FU, 5-FU, 5-FU until 2019. And we achieved partial response. Then we added docetaxel and vincristine. This is him in 2022. This is him in 2025. This have completely disappeared. no more, doesn't need any more treatment at that point. This is a post-mammoplasty patient in 2017 presented with what you are all familiar with, treated with the same method. The area you see to the right, to the left of this image, that has become a persistent site of recurrence. That one area has not responded to treatment. To this date, I treat that every 6 months or so. We talked about using surgery followed by intralesional chemo. I showed you this patient before. I'm going to share with you another example. This patient had this very large keloid. When you deal with these need to be removed surgically. I don't go treating this with cryo or anything. The aesthetic outcome is not even good. So once you resect it, you get a much better aesthetic outcome and then treat it with the same method, but in the line of surgery. And this is his most recent image. No recurrence there. Avoiding radiation therapy, basically. So another strategy is, again, we saw this patient in China, you may be using your punch treatment for this or operate, all kinds of methods of treatment. But when you have a bulky keloid, you can start with debulking it with cryo, use same method of chemotherapy. Afterwards, this needed 2 cryos. And then at this point, this patient had achieved complete remission. And this is a year later, this patient remains in complete remission with very decent outcome. So this is the intralesional chemo is an effective method of treatment. You have to properly select your patient and use proper doses, extremely low doses of drugs, and properly manage them. And these are the response rates that you can achieve with one of them. Again, these response rates would be validated once I do my AI assessment. Thank you very much. We can, please go ahead.
Well, I think we should discuss this because everybody does this in a different way. And I think it's very important because it's second-line treatment. Well, one comment and one question. One comment is, I think I saw a systematic review showing that the combination of 5-FU and triamcinolone would be more effective than either drug alone. Is there a reason why you don't do that?
I do that.
Oh, you do. Oh, I thought
So
the stepwise approach was
stepwise. So triamcinolone is included.
Oh, then you include
in
it
everything.
with
And you add
next.
5-FU.
Okay.
Next time you add vincristine to the 5-FU triamcinolone. Next time you add everything.
Yeah. And another one was about the dose. I mean, for the 5-FU, it was 1 milligram per milliliter.
Low. Yeah, you dilute it. I mean, you don't
most studies are 50 milligram per milliliter.
You know, unnecessary.
We don't know.
To use unnecessary because, yeah, if 5-FU is the only drug you're using, you're not using these other drugs, you try to maximize it. I understand that strategy. But if you have other drugs to use, you don't need to maximize the 5-FU. Luckily, 5-FU is a safe drug.
Yeah.
But vincristine is not. Docetaxel is not. There are intricacies in all of these that you need to know before you start treating these patients with these drugs. Vincristine causes pain. You need to be able to manage that. Docetaxel can cause allergic reaction. There is a profile for the patients. As young Asian female patients, they all develop allergic reaction during the injection right on the bed as you're treating them. So you need to pre-medicate them properly. It's 3 days of dexamethasone with H1 and H2 blockers. So any one of you is interested, I'll be happy to go through a lot more details on that.
I think it's good to use the lowest dose effective, but I don't think we have established the dose response for 5-FU in keloids.
That's correct.
But very important point, and maybe you could start with a low dose and then, or often people have multiple keloids. So you could try 1 keloid with a low dose and the other with a higher dose of 5-FU and triamcinolone.
Of course.
Well, lots of questions.
This one is a short one. Michael, did I hear you say you combined both vincristine and docetaxel? I see. So I'm just trying to think of it mechanistically, how that might be working, because I think docetaxel stabilizes microtubules and vincristine destabilizes microtubules.
They work from both ends of the microtubule.
Yeah.
One works on one and one. This comes, the principles I use are principles of oncology. You use combination chemotherapy for almost all cancers.
But vincristine and docetaxel are combined together in chemotherapy as well?
Works very well.
Okay.
Works very well.
Thank
you.
I actually have a few people who have been in my office and have seen the results of these treatments, have basically observed how I do that. It does work.
Are you mixing it all in the same syringe, or are you injecting twice? Because that may
Correct.
not all be stable in the same solution, the same pH, and these kind of things that our pharmacologists are very concerned about.
You're absolutely correct. None of what I do, none of it has been examined or assessed in the laboratory. The way I do it, at the beginning of the day, I mix my triamcinolone 5-FU mix in a large syringe. Then most of my patients get that combination. So I transfer that from a large syringe into a 1 cc syringe, 33 gauge. Now, if a patient needs vincristine, I draw a tiny bit of vincristine into that 1 cc syringe first, then add the mix of 5-FU and triamcinolone to that. If patient needs docetaxel, I'll take the docetaxel first in the syringe, then take vincristine into the syringe, all of them from the original vials, and then add the 5-FU triamcinolone mix to that syringe, and then mix it in the syringe before injecting it.
Okay, thank you.
Okay. So the next speaker, please.
Thank you, Mike.
Sure.
So I just wonder how to evaluate or how to choose when you face a small keloid, use chemo or use the cryo.
So, so when we start with the small keloid, say somebody presents first with a 2-3 millimeter lesion.
Mm-hmm.
So you first obviously start with triamcinolone and assess the response in about 2, 3, 4 weeks. If you see response, you continue with triamcinolone. If you don't see a response, if patient fails to respond to triamcinolone, then that patient goes down this path of then adding 5-FU to it.
Yeah, I mean,
I usually don't use cryo. I used to use cryo long time ago as a first-line treatment. Cryo is a messy treatment. When the keloid is bulky, like the one on the face, or these tumoral keloids, I always use cryo first to debulk. Then you reach a point that there's minimal keloid left in the base of that keloid and treat that with intralesional chemo. So what you don't want to do, you don't want to treat a very bulky keloid like the one on the shoulder that I showed. That for that one patient was proof of concept to see if this works. That keloid, I would first debulk it. If the goal was to get rid of that keloid, which in that patient was not, if the goal is if a patient presents with that bulky keloid on his shoulder, which is this big, I would first use cryotherapy to debulk it, then treat the base with intralesional chemo.
so most of the time, cryo you use for the
Ear.
ear.
Absolutely, 100% of time.
Great.
Unless the ear keloid is, say, 2 millimeters.
Okay.
If it is very small, if it is a papule, I would not do cryo. I would treat that with intralesional treatments.
Either those two methods after treatment, do you use the compression
Depends.
to stop the regurg?
Thank you for bringing it up. Yes, I use compression devices only if there is residual keloid left on the ear after trying cryotherapy. For instance, you have a patient with a keloid going through the ear, because with cryo, you're treating, removing anything that's protruding from the skin, through the skin. But then there is keloid tissue left within the body of the ear. That I would treat with compression devices. I would never use, Thomas, compression devices for a brand new keloid of the ear, because you have more effective treatments for that.
Could we have the next speaker, please? Going to present.
Yeah, the next speaker is Dr. Jin. Is Dr. Jin here? Dr. Jin?
What is the topic?
Jihu Jin, real-time effectiveness and safety of bleomycin. Okay.
Oh, okay.
So let's move to Dr. Oliveira. Do we have your presentations here? Can you put up your presentation?
In the meantime, one very short question and one very short answer.
Thank you. If you excise keloids on the shoulder, flank, wherever, are you also injecting right away with steroids or something?
Keloids in the shoulder area.
Yeah, you showed the picture with the flank where you excised right away the keloid, and I was just wondering if you also inject with steroids.
This one.
With that large bulky keloid?
Yes.
No, I would never, I don't think intralesional steroids are proper treatment for bulky keloids. To excise and then use, correct, I understand that. No, the topic is non-surgical treatment. I would not. Non-surgical. This is, as I said, we can treat these in a million different ways. The focus was whether or not we can treat these without surgery, without incorporating surgery. But for a very large keloid, the one that I showed you on the chest, that is very large. And that the only way you can effectively treat that is with surgery. And then you treat the line of surgery, the wound, starting 3 weeks later with chemo.